Good evening to all. Thanks for the Abraham and to give me this to be the moderator today. Without wasting any time, of course, today's topic is acute kidney injury, or you can name it also as acute renal failure. Of course, everyone who is sitting here would be knowing what is it, what is the cause. To tell more about it, we have our eminent speaker, Dr. BINU UPENDRAN, who needs no introduction. My knowledge is top rank gold medalist in his careers in every field. With these few words, I welcome Dr. BINU UPENDRAN.
Thank you, sir. Thank you for that kind words. As you all may have heard, it's my second, I think in the last 6 months, this is the second time I'm coming here. I'm so honored and privileged to be here. So let me share some of my thoughts about acute kidney injury. As you are aware, this is a hot topic, very commonly discussed. So I have nothing new to offer, but then some my own thoughts about this particular topic. One, as sir said, this is known as acute renal failure. At least for my generation, we all learned it as an acute renal failure in our undergraduate as well as postgraduate curriculum. So of late, the term has been changed to acute kidney injury. So why is this change? A lot of thought process has gone to it, and it probably means that it does not necessarily imply that the kidneys are at fault. And as it was previously defined as reversible decline in GFR or renal function. But then now we have learned that it is not completely reversible. Very often they can go on to what is called as acute kidney disease, which we'll discuss later. And the process or the pathology is not confined to the kidneys. It is most often extrarenal. And the occurrence of kidney failure or acute kidney injury is an independent predictor of mortality. So much so that you can say that a patient with acute kidney injury, when he has a multi-organ failure, the mortality or the adverse event is 4 times. Needless to say, if it is in the ICU, it is around 50%. So that is with regard to acute kidney injury. Now, how to define acute kidney injury? There are many classifications. This is what is given in Harrison. The stage 1 or risk when you have a 25% elevation in creatinine or an output which is less than 0.5 ml per kg for 6 hours. Or a stage 2 when you have a 2 to 3 times elevation in serum creatinine with a GFR decline of less than 50%. So this would equate to GFR urine output less than 0.5 milligram per 12 hours. And stage 3 when there is a 3 times elevation in serum creatinine and a 75% decline in GFR or less than 0.3 ml per kilogram per hour reduction in urine output. For all practical purpose, this is what we consider in our hospital or our setup. When the urine output is less than 30 ml per hour for 6 hours, we qualify them to be having acute kidney injury. And if the creatinine goes above 30% over the last 24 hours value, we consider it as acute lung injury. Needless to say, when the patient goes in for a abrupt worsening requiring renal replacement therapy, we would call it as an acute kidney injury. So that is how we practically define acute kidney injury. Now the etiology and pathophysiology, as I said, it is predominantly a non-renal disease. So it is applicable to all of us clinicians here. So as in our undergrad studies, it is pre-renal, intrinsic and post-renal. Pre-renal, there are several causes where there is an effective reduction in blood volume and commonly occurs in hypovolemia due to various reasons, cardiac output, low cardiac output states or congestive cardiac failure, liver failure and so on. And most often it is due to drugs where there is a filling of the renal vessel is less, as in NSAID or ACRB or cyclosporin. Then it can be a post-renal where you have a bladder outlet obstruction. Now there are several intrinsic renal causes, we'll come to it. These are the intrinsic renal causes There are small vessels, it is compartmentalized into small vessel tubules, intratubular, then interstitium and large vessel. Interestingly, there are some reports of pantoprazole associated acute kidney injury as well. So if you look at the interstitium, it is commonly drugs or allergic. Common drugs can be rifampicin, it can even be pantoprazole, as I said. It can be due to acute pyelonephritis. There are tubular obstruction which cause it, which commonly is due to myeloma cast. There can be the acute intrinsic tubular necrosis, as previously called as ATN, is commonly due to various toxins which can be endogenous as well as exogenous. We recently had a patient with acute kidney injury following severe exertion, and the diagnosis was an acute rhabdomyoglobinuric renal failure. So there are umpteen causes of acute kidney injury. Most of them are in the purview of the clinician, and most are in the purview of the physician. And now, coming to the natural history of the disease, there is initiation where there is injury, there is an extension phase which goes into a maintenance phase, and then recovery. The usual period of recovery is 6 to 12 weeks, but then most often it recovers within a period of 2 weeks. So that is how it is. Now, coming to there are several indices which have been discussed. This is how we look at the urine. If you have a few RBCs or a hyaline cast in urine, we would presume it is a pre-renal cause. But specifically, RBC cast would put it as vasculitis. WBC cast would put it as pyelonephritis. Tubular epithelial cells as an evidence of ATN, and then crystalluria for various forms of drug-induced acute kidney injury. Eosinophilia is unique in the sense it is due to acute interstitial nephritis. So there are several indices which have been discussed, very cumbersome and complicated. I'll not go into it. What we practically do is to give 60 milligram of furosemide or 1 milligram per kilogram of furosemide or Lasix and wait for 2 hours. If the urine output is more than 200 ml in the next 2 hours, we would presume that there is no severe forms of acute kidney injury that would require dialysis. So in such patients, we continue with the conservative therapy. And when it is more than 200 ml, we presume it is due to pre-renal factors and continue to hydrate the patient. So that is how we do in our hospital. We give 60 milligram of furosemide, observe for 2 hours. If the urine output picks up to more than 200 ml or 200 ml, we continue with conservative management. Don't subject them to dialysis also. Now, the treatment, as I said, it is extra-renal treatment. We have to remove the inciting event, which is most often a drug or a contrast or material that is used for investigation. You have to correct the volume status. We, as nephrologists, we try to maintain the milieu interior. And the lung protection is of paramount importance because pulmonary edema can be lethal. Subject them to renal replacement therapy is required. And of late, a lot of centers have started using extracorporeal endotoxin, cytotoxin removal. We'll discuss a bit about it. Now, deficiencies, this is what is the standard of care for acute kidney injury. What is the future of treatment of acute kidney injury? This is very relevant because creatinine elevation occurs late in the disease. If you consider a similar situation in the cardiology side, an acute MI, there is an elevation of troponin before the drop in the cardiac output or ejection fraction. So there is a time period between the onset of dysfunction and the onset of injury. So the intervention is delayed in the current setting where we look at creatinine only. So the systemic effects can be overwhelming in these situations. So this is how evolution of acute kidney injury would be like. So in the initial phases, it is normal. Subsequently, the injury develops, which is not clinically evident or biochemically evident. Later on, the patient starts having an elevation creatinine. By then, the disease is very late. So this is the natural history of acute kidney injury. It goes through the stage 1, stage 2, and stage 3. But prior to that, there is a period where there is a risk when the pathology is not recognized, where we have several markers which has come into the market, at least for in the West it is commonly used. The idea is to intervene at this point of time so that progression to acute kidney injury can be prevented. So these are the injury markers which have come into being. Kidney injury molecule, neutrophil gelatinase associate lipocalin, SUPAR or a soluble urokinase plasminogen activator factor receptor, IGF, beta, TIMP2, and so on. So these are all markers which are available in the market. FDA has approved some of them, and it is being used in some critical care centers. But then nothing much can be done about it. This is what if we are able to predict the occurrence of acute kidney injury early in the stage of the disease. So if you can diagnose it as at A, B, and C, it can be reversed at that point itself before going in for the maintenance phase. So by and large, it can be treated or reversed if you can diagnose it earlier also. These are the molecules which have come into being. Now, coming to one specific form of acute kidney injury, that is the sepsis-associated acute kidney injury. It is said that around 50 million people are affected worldwide, and 20% of them die despite the best of care. And most of them are without, most of the acute kidney injury can occur without any hemodynamic change. That is to say, even without hypotension, they can develop acute kidney injury. So the pathology is varied, not just the hemodynamic changes which lead on to acute kidney injury. The pathology is believed to be generalized arterial vasodilatation. Endothelium is often the victim as well as the villain because it secretes several cytokines. We'll come to it. There is interstitial edema in the kidney. There is organ microcirculation leading on to multi-organ failure, and the cytokine storm which perpetuates it, which we have learned in the COVID times. Now, this is what I said. The disease progresses from an anti-inflammatory state to a pro-inflammatory state. So probably if you can intervene in the early phase, maybe we can treat it and reverse the acute kidney injury which has occurred. That is one thought which has gone. So most of the centers, even in our own town, started using acute extracorporeal therapies. The idea is if you intervene early in the disease, we can remove the toxins. Pro-inflammatory cytokines as well as endotoxins are removed. It is used early in the disease before the idea is to remove pro-inflammatory cytokines, and it is done before lactate levels peaks. And new markers, as I said, can be used as a guideline for initiating this particular treatment. There are several cartridges available of varying cost, ranges around 60,000 to 1 lakh. And the idea is to remove endotoxins, cytotoxins, as well as plasma exchange can be done. And there is a selective cytopheretic device which has come into being, which can remove the pathogenic forms of leukocytes as well. So all these therapies have come into being for early intervention in acute kidney injury. So these are the different types of devices available. There are different types of pathogens, and polymyxin, cytosorb, and oxidase are the 3 different types of filters which are available in the market now. It's around 60,000 to 1 lakh per filter. It can be used for 6 hours and it has to be replaced. So that is how the extracorporeal therapies are. This is the circuit for extracorporeal therapies. It's been extensively used, at least in major centers. Now, what is the last word regarding this? Till date, there is no conclusive evidence that has emerged to support the routine use of any of these modalities as an adjunct to standard therapy of sepsis. Patient specific needs and resources must be assessed, and clinical acceptance is still limited due to lack of randomized controlled trials. So even though it is being commonly used, there are no guidelines or textbook description of this particular therapy, but then it is being used if you can pick up the patient early in the process. Now, acute kidney disease is a new emerging entity which has been more described during the period of COVID. The syndrome is when the creatinine remains above normal 6 weeks to 12 weeks after the onset of acute kidney injury. As I said, the previous concept was that it is a totally reversible decline in renal function. But then over a period, we have learned that it is not totally reversible very often. And persistent acute kidney injury can lead to chronic kidney disease. Severe and prolonged effects of acute kidney injury is what leads to it. And elderly and hypertensives are more prone for it. COVID-19 was one of the important lessons when we learned about this pathology. Basically, there is fibrosis going on, which goes on to a stage where there is irreversible kidney damage. Now, to conclude, acute kidney injury is a systemic illness. It is not an organ-specific illness. To see it in the entity as a physician would view it as an organ, as a part of a symphony orchestra is what is needed. It cannot be viewed in isolation. Of course, every specialist gets involved when you have a patient with acute kidney injury. Early treatment and early recognition and treatment is very gratifying, as this is completely reversible if you can intervene early. The science of acute kidney injury is exciting, and hopefully we will have more therapies in the future. The future is unraveling and promising with each passing day. So we learned a lot about acute kidney injury in the last 1 decade, and hopefully we'll continue to learn this. I'd like to sign off with one eminent scientist, who is Jens Christian Soko, who was awarded Nobel Prize in 1997. He was from Denmark. He was awarded this for the first discovery of ion transporting systems, that is sodium potassium ATPase, which we all endeavor to keep active in various ways, like antibiotics, revasculation, and so on. So the science of acute kidney injury revolves around this particular enzyme, which maintains cell homeostasis. Thank you.
Thank you, Dr. BINU, for a lucid talk. Any comments, questions are open for discussion. One, I'll start the poll. Is nowadays, for my doubt, why urea is not included nowadays in the blood?
As I said, acute kidney injury is not a disease which is confined to the kidney. Likewise, the urea level varies depending on many factors. Like if there is a hypercatabolic state, or a patient is on steroid, there is more of gluconeogenesis occurring. In this, there is extensive protein breakdown. Protein is converted to glucose so as to maintain the glucose level. So when there is a hypercatabolic acute kidney injury, there is more muscle breakdown, more protein catabolism, and that leads to elevation in urea. So urea may not be directly indicative of an acute kidney injury. And second reason is, if there is an oliguria, the kidneys, the tubules try to avidly reabsorb the urea. So the urea can be falsely elevated when the patient has got a normal renal function, or when the renal function is not severely elevated. And most interestingly, in patients who are hyper alimented, when the protein intake is augmented, they tend to have high urea. And intriguingly, in patients who have chronic liver disease, an elevation as urea is considered as a good sign, because it means that the liver can synthesize more urea and the liver functions are fairly well preserved.
Thank you, BINU. Any questions from the audience?
You give furosemide the infusion also, apart from IV bolus.
We also do give Lasix infusion. The idea is to delay dialysis or to avoid dialysis. If your patient has got the treatment of acute kidney injury is different from chronic kidney disease. For a patient with chronic kidney disease, we try to delay dialysis as much as possible. The idea is that once you put them on dialysis, the urine output goes down. So we try to prolong dialysis by giving higher doses of diuretics. We go to the extent of giving maybe 200 milligram of torsemide to keep them euvolemic, so as to avoid dialysis. But in an acute kidney injury setting, if, as I said, the Lasix challenge, it is even described in the latest volume of Harrison. You can give 1 milligram per kilogram of Lasix and wait for 2 hours, see the direct response. If there is no diuretic response, maybe in a setting of an acute kidney injury, it is worthwhile to put them on dialysis.
So how long does it take the creatinine to come up after a kidney injury or anything?
Very, very relevant question. The answer is we still don't know. That is why we have all the other markers. By the time creatinine starts increasing, the kidney functions would have remarkably come down. So much to say that a doubling of creatinine would indicate around 50% loss in GFR. So the creatinine elevation takes time. It depends on the rapidity with which occurs. So if there is a sudden decline in renal function, probably the creatinine goes up faster. But a slow decline in creatinine, the body adapts to it and probably may not be an indicative of the underlying renal function.
Any questions? Raju sir?
In all case of pre-renal failure, we initially give fluid challenge before we give Fruzman. Don't we do that?
In clinically hypovolemic, it is mentioned that if the patient is clinically hypovolemic, you can still give a challenge of 200 milligram saline over a period of 1 hour for 2 hours, and then try challenging with the Lasix. But then we have to be very sure that the patient is hypovolemic.
We can do a bedside echo for that. We can look at the IVC.
You can look at the IVC. Let me ask from the other side. I have seen many patients developing mild elevation creatinine following initiation with fenofibrate. So I don't know, it has not been mentioned in many books. Very often when we start fenofibrate in combination or in isolation, there is a mild elevation in creatinine which comes down after stopping fenofibrate. Theoretically, it is possible because fenofibrate acts on the muscle and probably the creatinine comes down from the muscle. But then it is one clinical, I've seen at least in several patients this type of changes. So acute kidney injury due to drugs is not uncommon. Even pantoprazole is known. There are reports of pantoprazole producing acute kidney injury, not in the long run, but I don't know.
Even I don't know. Any more? If there are no more questions, thanks, Dr. BINU, for your wonderful. Thank you very much.